let's get started. So on behalf of the COBRA on Opioids and Overdose in Rhode Island, the West Virginia Clinical and Translational Science Institute, the West Virginia Idea Network of Biomedical Research Excellence, the Rural Drug Addiction Research COBRA in Nebraska, and the Center for Addiction and Disease Risk Exacerbation at Brown University in Rhode Island, we would love to welcome you this morning to the 2023 Symposium on Substance Use Research. My name is Tracy Green, and I am co-directing the COBRA on Opioids and Overdose at Rhode Island Hospital with Dr. Jody Rich, and very excited to see everyone this morning. I wanted to start by saying that this is our 4th year hosting a virtual symposium, and we're excited to have the opportunity to share substance use focused research broadly, and we hope that you can join us this week for all of our symposium programming, including our keynotes, several panels, a poster session, and short research presentations. A few quick reminders before we begin. This session is being recorded, and we will send an email to registrants and post on social media when the recording is available. Also, this session is a webinar, so attendees will be muted. Please use the Q&A function at the bottom of your screen to submit questions, and then we'll try to answer them as time allows. We'll also have a chance to interact at the end of the session to ask questions of the speaker and exchange. I'm honored to be introducing our first keynote of the 2023 symposium, Dr. Stacey Sigmon. Dr. Sigmon is a professor in the University of Vermont's Department of Psychiatry with a secondary appointment in psychology. She has conducted behavioral pharmacology and clinical drug abuse research for 30 years, with a primary focus on developing more efficacious and accessible treatments for patients with opioid use disorder. For 2 decades, she has also investigated cigarette smoking and nicotine replacement enforcement among smokers with concurrent substance abuse and other medical issues. In addition to her program of research, she has served as director since 2004 of the first and largest opioid treatment clinic in Vermont, which presently treats 1,000 opioid-dependent Vermonters. She now leads one of 3 national rural centers of excellence on substance use disorders, the UVM Center on Rural Addiction, which is dedicated to disseminating science-based treatments and tools to expand treatment capacity and reduce opioid-related morbidity and mortality in the rural areas that are so disproportionately impacted by the current opioid epidemic. Thank you for joining us today and for sharing your expertise with us. And the title of today's talk today is Expanding Addiction Treatment in Rural Areas, Experimental and Implementation Science Efforts. So please welcome Stacey.
Thank you so much for that wonderful introduction, Tracy. It's a pleasure to be here. I really appreciate being invited to this such a great lineup of presenters in your conference and topics. And so, as Tracy just noted, I was hoping to share kind of a two-pronged approach here on our work in at the University of Vermont in particular. One, focus on some of the prospective randomized clinical trials, the experimental efforts that we've been engaged in the past few years on the topic of rural addiction and in particular rural opiate use disorder treatment. And then following that with telling you a little bit about some of our more recent efforts to in the implementation science space in terms of helping to disseminate evidence-based tools and methods and knowledge and resources to the rural healthcare providers that are very much on the front lines of the rural opioid epidemic. And not only in Vermont, but nationally, actually. So I will begin. Let me see about sharing. Someone just let me know if you can't see this.
It's perfect.
Good. I was going to just begin with a brief disclosure statement of the funding sources that have supported my work and studies, with the top 3 bulleted here being the ones that the funders of some of the data that I'll be sharing with you in the first part of the presentation, as well as HRSA, which is the funder of our implementation center. And so, as I think probably by now all of us are very much aware, the United States opioid epidemic certainly remains a very serious public health crisis, and even more so in the past several years as we've experienced this recent emergence of fentanyl and other really potent synthetics, xylazine more recently. And we all, know that the agonist medications for treating patients with OUD are highly effective at eliminating, reducing illicit opiate use and other drug use, reducing morbidity and mortality associated with illicit opiate use, as well as the spread of HIV, HCV, and other medical consequences. And however, despite the clear efficacy of these treatments, kind of a longstanding issue is the insufficient or suboptimal capacity of MOUD treatment availability in rural areas. Not only in rural areas, but it seems to be often especially pronounced in our rural communities. And this has looked kind of differently, or depending on where you live, especially in our area and a number of others. We experienced lengthy wait lists for treatment, especially in the clinic-based, the opiate treatment programs, and especially for subsidized treatment slots. And then in terms of office-based buprenorphine treatment, we and others have often just experienced significant underutilization. So if we look at the US as a whole, recent data have shown that greater than 1/3 of all rural and greater than 1/2 of small and or remote rural counties lack even a single buprenorphine prescriber. And then when you do have a provider prescribing buprenorphine to patients with OUD, by far most of them tend to carry far fewer patients than they're permitted or allowed. And in terms of our experience in Vermont, in particular, we very much shared these same challenges. So by around 2013, our opiate treatment program had reached almost a 2-year wait list between the time that patients called us to seek treatment and then whenever the next treatment slot became available. And while for years, Vermont, we had the highest per capita number of buprenorphine providers in the country, when we look at the utilization, the actual number of patients for whom they were prescribing, our average utilization rate was about only 10% of the maximum possible. So significant underutilization. And so we, in the past 10 years, or so, have really been engaged and interested in experimental efforts to explore and develop and evaluate new approaches that might be useful for expanding availability of MOUD treatment, as well as harm reduction in general, but especially in the rural geographic areas. And so today I was going to share with you some of our most recent efforts focused on developing and evaluating a technology-assisted buprenorphine protocol that might extend life-saving pharmacotherapy, as well as harm reduction support to rural patients, while also including some tech-assisted components to support patients' clinical stability and adherence to the medication regimen. So in terms of the various components that we kind of integrated together for this treatment protocol, there are 4 or 5, and I'll go through them briefly here. The first was buprenorphine dosing made available through kind of a mobile computerized dispensing device. And so this was, again, an effort whenever we did have the take-home doses to help support patients' timely taking of the medication, no selling, sharing, trying to reduce the probability of unintended pediatric exposures, not only because it's important for their clinical adherence, but also because often that's what the providers, when they had reluctance to take on to treat more patients, they often cited these potential risks or challenges as some of the barriers that were keeping them from treating more patients, is concern about either medication non-adherence or selling or sharing of medication. So in this instance, we found a pretty small portable computerized device. And in this trial, patients came into the research clinic here at UVM twice a month to ingest that day's dose in front of the research nurse, but then they received 2 weeks worth of take homes during each interval between each study visit in this device. And it also included some safeguard features as well to help prevent selling or sharing, and that included all the doses being locked away so that they were generally unavailable outside of the dosing time, as well as kind of an alarm that if someone tried to break into the device, it would alert us. Another technology component that we developed and used in this was an interactive voice response system, so kind of a phone-based system. And we developed it for 2 functions, which I'll describe, but generally it's kind of the system that whenever you call your credit card company, so you get kind of recordings, you can interact with a numerical keypad, make choices, enter data. And then also this system had the ability to, if the person was in crisis or wanted to speak to one of our study staff members, to just hit a key and be connected immediately with us. But the first kind of functionality that we developed with this IVR system was for it to generate nightly calls to the patient, just to simply check in, assess any opioid use, withdrawal, craving, any crises or problems. Those calls also included, if they accessed it, if they were interested, information about support groups and resources going on in the community. And again, also included a way for them to connect with us immediately if they had any concerns. And it sounds kind of lengthy, but I think actually the average duration of these calls tended to be about 1.5 minutes. So we also tried to balance things so that they weren't super onerous. And we also had the IVR system dispatch the calls to them so that patients wouldn't have to remember to call in, but they did have that flexibility should they want to call us instead, or if they anticipated not being available at the time of the usual nightly call. The second function for the IVR system that we developed was to support random callbacks. And so random callbacks are a pretty standard feature in methadone clinics and other opiate treatment providers for decades, whereby the patient gets a call randomly with little advance notice. They're told that instead of ingesting that day's dose, to instead come into the clinic, ingest it take it in front of a nurse, and the nurse often does a pill count at that time and does a quick kind of clinical check-in to make sure they're doing okay, and often will also get a urine specimen as well. And they're kind of a pretty tried and true feature to both support clinical stability, adherence, as well as to reduce diversion risk. However, they can be pretty labor intensive for the staff at the clinic, nurses or others who are in charge of generating these calls. And so we were hoping to surmount this barrier by moving them to an automated platform with the IVR. So the IVR system would call, there was a web-based interface that we would use to schedule the date and time of each patient's random callback, and track it and monitor things and control. But the call itself was very automated and nicely went out to the participant at the time that we chose, with the instructions along the lines of what I just described. And then lastly, we wanted to find a way to provide some HIV and HCV prevention education, but to do so in a way that was pretty efficient and to use kind of a more self-administered technology platform. So towards this end, we developed an iPad-based self-administered educational component where the patient would interact with some videos and content both on HIV and Hep C prevention, as well as the iPad delivered a knowledge assessment both immediately before the educational intervention, so that we could get some a sense of their baseline knowledge in these domains, as well as immediately following the single session mobile health educational intervention, and actually at later time points throughout the trial as well, to see if if there were any knowledge gains as a function of this single session iPad delivered educational component, whether they also might persist over time or not. So the design for the first study was a 12-week outpatient pilot to just first seek to get our head around any initial feasibility and efficacy of this technology-assisted BUP protocol. Participants were 50 opiate-dependent Vermonters who were randomized to either IBT or waitlist control. As I just mentioned in the previous slide, the folks randomized to receive the buprenorphine treatment visited the clinic about twice a week as scheduled visits to ingest their dose, provide a UA, and then receive those 2 week intervals of medication of buprenorphine to take it home via the portable computerized dispensing device. We provided additional harm reduction supplies, as you see here, and they received those nightly IVR calls for check-ins. And also the IVR generated random callbacks at about a twice per month frequency. And then in addition to the comprehensive intake assessment that we used at the beginning to evaluate eligibility before participants were enrolled and randomized into the trial, we also conducted monthly follow-up assessments throughout. And that, again, often is our primary outcome so that we can see if folks, how they're doing not only in the primary outcome of illicit opiate abstinence, but also in a number of other domains. The participants that were randomized to the control condition completed the same 4, 8, and 12 week follow-ups, as well as receiving all the harm reduction supplies, resources, as well as information packets and assistance and referrals to receive treatment elsewhere. So by them being randomized to the control group, it did not prohibit them from going and getting treatment if they wished elsewhere in Vermont. We would just track that in our data in the monthly assessments. And then should any, if they had not gotten into treatment or it had not become available elsewhere during that 12 weeks, then at the end of that first study period, all of the control folks were offered an opportunity to cross over to receive the same IBT treatment for the next 12 weeks. So I'll jump straight to our primary outcome, which again, as I said, was the percent of participants that provided a urine sample at each of the monthly follow-up assessments that tested negative for illicit opiates. As you can see at the intake time point, that was 0%, as you might expect, prior to treatment, prior to the study. And then we saw robust and statistically significant increases in the percent of participants who were randomized to the buprenorphine group to provide a sample that tests negative for illicit opiates. About 87 or so percent, or 88, 84, and 68% testing negative for illicit opiates at the 3 time points throughout the study versus 0 in the control group. And all 3 of these time points were significantly greater than controls. There seemed to be kind of a pattern, a possible trend towards a downturn in abstinence towards the end of the study, but that wasn't a statistically significant decrease. We also, additional secondary outcomes were intravenous drug use. And so we conducted a timeline follow-back assessment interview at each follow-up assessment time point, asking how many days in the past 30 participants had injected opioids. And here too, you can see they came into the study on average, injecting about a week out of the past month. So a lot of these folks were, maybe their primary route of illicit opiate use was intranasal, but then they still, engaged in pretty frequent rate of high risk IV drug use behavior. And that rate in the folks who were randomized to the buprenorphine tech-assisted treatment dropped to near 0 levels for the remainder of the study. Whereas it remained fairly stable in the control group. In terms of some secondary outcomes, that mobile health single visit iPad self-administered educational component that I mentioned, we saw significant effects on both of those as well. So to the right in the first bar, you see the kind of baseline levels of accuracy of knowledge of participants' knowledge about HIV risks, transmission risks at the top panel, and hepatitis C in the lower panel. And following the single session educational module, we saw significant improvements on both of those. And then more surprisingly, those improvements were actually sustained for the duration of the 12-week study. And that was without kind of additional booster sessions or additional education. So, to us, these pilot data seemed promising. They supported an initial efficacy of this technology-assisted BUP protocol. As I mentioned, we were a little concerned seeing that trend towards a downturn in abstinence towards the end of the 3-month study. We certainly wanted to make sure that that wasn't really a thing, and that if patients were given this treatment for a longer duration, you wouldn't want to see the effects dissolve over time. So that was a lingering question for us that we wanted to follow up on. We also, when we looked back at the sample that was enrolled and randomized, the majority of them in Vermont, which is a rural state, but actually they lived kind of near the University of Vermont, our campus in Chittenden County. And that turns out to be Vermont's only non-rural county. So given everything I said a few minutes ago about this emergence of a rural opiate epidemic, we were very much interested in seeing how these effects might generalize or not to rural residents. And then lastly, when we looked at the baseline characteristics of our participants, 30% had reported having previously overdosed, with on average almost 4 overdoses per person. But we had not included at that time a formal overdose. We provided the harm reduction supplies, but no formal overdose prevention component. And so that was something else we wanted to follow up on and improve upon. And so we then conducted 2 follow-up randomized trials to programmatically build on some of these in these areas. So we sought to replicate and test the generality of the kind of promising pilot study findings, to evaluate whether these good outcomes would persist over a longer duration, to look at whether they may hold with folks squarely living in rural, medically underserved areas, and then again to incorporate an educational component laser focused on opiate overdose risk. So we next conducted 2 parallel randomized trials, and they're both largely similar in the ways that I'll describe here. So both were 24 weeks in duration, the longer duration. Both enrolled 50 participants. The difference is that trial 1 was to kind of seek to replicate our pilot study findings still in the largely non-rural folks living in Chittenden County, whereas trial 2 specifically enrolled folks in a HRSA designated rural county, so not in the proximity around UVM here. And to help disseminate that part of the study, we established kind of a mobile treatment team that previously just stayed at UVM for all study visits, and they actually would travel out to the rural counties to conduct the study visits in an effort to try and reduce the pragmatic barriers and cost and transportation, childcare barriers that our rural Vermonters tend to experience. And so we worked to set up some rural study sites with some of the municipalities and partners here that I list, so that we could conduct our visits in a confidential office at a site that was near and convenient to the participant. And then overall, the same tech-assisted components that I just described were included in both trials, with the addition of, as shown here, a mobile health iPad-delivered overdose prevention education. And so that was developed in partnership with some of our colleagues at Johns Hopkins, Kelly Dunn and her team. Just like the HIV and Hep C iPad modules, participants first completed a pretest assessment of baseline opiate overdose related knowledge. And then there was an interactive educational platform and video. We too provided the harm reduction supplies and instructions on how to use those, and then followed up with post-test assessments of overdose knowledge using a similar approach as I described for the others. So to cut straight to the primary outcomes, on the left panel, you'll see the primary outcome of illicit opiate abstinence for trial 1. On the right, trial 2, so non-rural and rural. And as you can see, the Participants that were randomized to the tech-assisted buprenorphine treatment provided significantly more urine specimens that tested negative for illicit opiates at every single time point in both trials compared to the control group. Here you see a little more increasing in abstinence in the control folks, and that's because over time, compared to when we conducted maybe 10 years ago now, our pilot study, treatment is more available in Vermont. And so we were able to refer folks in that group into treatment elsewhere. And that's kind of accounted for here. But still, there were significant differences between the experimental groups on this primary outcome. Similar, not a lot of differences, if any, between the rural and non-rural participants on these outcomes. So still favorable outcomes, significant differences between experimental conditions, similarity between the rural and non-rural settings and populations, and thankfully a persistence of the absence rates in the longer duration. So if you recall, the pilot study was 3 months long. This is now 6 months, and we're not seeing that that marked downturn in absence towards the end, or even at month 3, like we saw in the a hint of in the pilot study. Adherence rates for various other parts of treatment were also quite high and similar between the two studies. So about 99% of all of the buprenorphine doses were administered as scheduled in the devices and the ones in person. 93% of those daily, nightly monitoring IVR calls were completed satisfactorily, and 92% of random callbacks, which is far better than we even typically see in our methadone clinic in the community. And of those urines, you might think, well, it's not too impressive necessarily for someone to provide a urine sample that tests negative for illicit opiates for, say, a monthly urine that they know they can plan their life around. They know when, what day, what time. But I always find a bit more compelling too that 98% of the urines from the random callbacks were also tested abstinent for illicit opiates. So that kind of further validates our outcomes, because since participants did not have really much advance notice as to the timing of the random callback visits. On the outcome of HIV knowledge, we saw a similar effect as I described and showed for the pilot study. And so that kind of brief single visit iPad delivered mobile health intervention on HIV knowledge was associated with a significant increase in accuracy and knowledge between the pre and the post assessments, before and after that component module. And then actually this time those knowledge improvements persisted now, not just over the 3 months study like the pilot, but over the 24-week duration. And similar to the primary outcome of illicit opiate absence, we saw similarity between the non-rural and the rural participants and settings. Similarly, similar findings with the hepatitis C. So again, we saw significant improvements in hep C knowledge, prevention knowledge between the pre-test and the post-test. So before versus immediately following that iPad delivered hep C knowledge education module. And then that too persisted over, largely persisted over the duration of the 24-week trials, and was similar between the non-rural and the rural studies. The new piece here is the opioid overdose knowledge mobile health educational component that we added to this. And on this too, we saw also a similar and consistent finding with statistically significant improvements as a function of that associated with that intervention, which also were sustained over time, and similar patterns across the two trials. So these two trials were just finished about a year ago, and were recently published last month, I believe, in JAMA Network Open. Overall, they replicated the initial findings in the pilot study. The high rates of abstinence, good adherence, nice outcomes associated with the mobile health educational components on HIV and HCV. These two studies provided some data to extend to a longer duration to rural patients and to the domain of overdose-related knowledge as well. And so taken together, we really have been excited that these and many other mobile health platforms and technology-assisted platforms, combined with efficacious pharmacotherapy, may go a long ways towards expanding the treatment need, the capacity in rural areas and other underserved areas and populations. And while this is all fine and good, often, we publish a paper on the outcomes, primary, secondary, but at the end of the day, we're kind of left grappling with the question, especially when I wear my community treatment clinic hat, of how can we do a better job of getting these and other resources and information and treatments actually into the hands of the healthcare providers that are on the front lines of the opiate epidemic in the rural areas, because they often don't have a PubMed subscription and an affiliation with an academic medical center. And so we've got to really do more about towards disseminating information about these studies, but so many others, that exciting studies that are taking place. And so that led us to establish in 2019 the University of Vermont Center on Rural Addiction. And UVM Cora was established along with two other rural centers of excellence in the US by HRSA, the federal agency, who basically charged all of these centers of excellence with the mission to support the rural providers and staff across the country in the rural HRSA designated rural communities, counties, in their efforts to treat patients with the overarching aim of expanding capacity of evidence-based addiction treatment in rural counties. Our center-specific objectives have been to provide consultation, resources, education, outreach, TA, largely all laser focus on evidence-based best practices to healthcare providers and staff, policymakers, even some families and community members in the rural counties. Our kind of three-pronged strategy to do this has been to focus on first identifying the real-time needs, so kind of going to the providers themselves and collecting data and having them tell us their kind of their real-time challenges, barriers, strengths, successes, to get straight from the horse's mouth where the needs are and the barriers are in the rural counties. Two, then, is to deliver, based on that information that we gain, deliver ongoing support, TA, workforce training, to support the dissemination of best practices for expanding capacity. And then also to disseminate education, outreach, and other resources on treatment and prevention to these rural providers. And so in a minute, I'll provide some actual tangible examples of what that means, because I find that helpful to talk specifics. But first, I'll share the four cores that our center consists of that kind of align with these aims that I just shared. The surveillance and evaluation core is essentially a team of staff and faculty who, over the past 4 years has been conducting baseline needs assessments and other surveys and efforts, individual consultations, focus groups, to identify the real-time barriers being experienced by rural providers, as well as to assist in some data systems and tracking of drug use patterns and the like that you see here on an ongoing basis when a rural provider or practice could use some help with their data systems. The best practices core and team essentially provides all types of in-person as well as remote support, technical assistance, consultations in evidence-based practices, as well as hardware, software, really tangible things like harm reduction supply resources. And I'll show again some examples in a minute in the next slide. The Ed and Outreach team conducts a pretty robust schedule of everything from community rounds webinars with associated CME credits that get archived as well, with presentations and discussions on evidence-based treatments and methods and interventions, prevention, relevant to rural addiction. And then there's a range of other platforms, from newsletters, research spotlights, which seek to translate maybe a complicated randomized trial and outcomes publication that, again, a provider only has access to if they are maybe affiliated or also on the faculty of a university or a medical school, translate them into an easy to digest one-page research spotlight to try and get out the knowledge and the information about an exciting evidence-based new treatment to a larger audience than just those folks who have a subscription to PubMed or to a university library. And then our clinical and translational team and core is a fantastic group of clinicians, really often champion like buprenorphine providers and other physicians and psychiatrists and faculty and staff that are there kind of as a 24/7 resource for isolated rural providers, such that when they have like a complex patient with co-occurring needs or a challenging induction or, you know, whatever the question is, this team provides one-on-one peer mentoring, consultations, in person, phone, Zoom, across different platforms, as well as an in-person 2-day training, like a scholarship program where these rural providers can actually travel to UVM and get hands-on support and training in the areas, the challenges that they identify having a need in. Just a couple of slides on actual examples of what we're talking about, because it can be hard to kind of picture, you know, these as I'm talking about our aims, or higher level kind of aims. So certainly on the left, you see some examples of like harm reduction resources and supplies that there's been a big hunger for. We get a lot of requests from providers, programs, community programs for these, and they include Narcan, intranasal naloxone, disseminated in all kinds of ways, not just in the straight up box that we often hand out or mail out, but also with wall mounted units, vending machines, and the like, to really reduce the barriers and offer 24/7 discrete availability of intranasal naloxone. Fentanyl and xylazine test strips are becoming increasingly important. Different consultations on, as I said, how to induct a patient onto buprenorphine or methadone, or to taper them down, or to address a patient's OUD, opiate use disorder treatment, in tandem with their pregnancy or their pain or their co-occurring psychiatric issues or other comorbid medical issues. That's a big focus of the questions and the requests for support that we're getting from rural providers. Safekeeping of medication, as I said, that's important to helping more providers feel comfortable in prescribing take-home doses, you know, of MOUD medications. And so there are a variety of ways and hardware and supplies that we can provide to them to use. I'll try to be quick here. This middle section on co-occurring issues, that's a huge area of focus of requests that come in terms of, as I said, having providers having, you know, if they don't have expertise in addiction necessarily, or special populations, addiction psychiatry, it is really challenging to treat a buprenorphine patient in your general medical, you know, practice, who also is using cocaine or methamphetamine, smoking, alcohol, benzos, has depression, anxiety, trauma, PTSD, pregnancy pain. All of these, often, you know, 2 or more of these co-occurring conditions and challenges really, you know, represent a challenge to the providers. And so that's been a big kind of theme that especially our clinician advisory board has seen in terms of requests for support and consultations to rural healthcare providers. And then also, you know, as you see here, some more systemic consultations about, say, for example, there's a hub and spoke model for how to expand buprenorphine treatment in an office-based setting. You know, there's interest often among folks. It began in Vermont, but there's a lot of interest in other states about how to maybe adopt or adapt a hub and spoke type system for your own needs in your community. And other examples here, I'm happy to talk about any of them in the Q&A section if anyone has any questions or interests, or by email after. Taken together, so Cora and the other two centers were established by HRSA in 2019, so it's been just over 4 years. And our mandate from HRSA was first to focus on New England, but since then we've really quickly expanded to where in these 4 years we've now supported over 32,000 rural providers across all 50 states. Mainly the providers just need to be located in a HRSA designated rural county, which you all are probably familiar with from your own rural addiction work. Some examples of what, if you think of those tangible examples of the types of resources that we've provided, here you can see kind of some stats, some impact stats on what that looks like. So over about 6,700 rural providers have attended those community round sessions that I mentioned, and over 500 CME credits claimed so far. The scholarship program that I mentioned, where folks can travel, we cover their cost for travel to come to UVM and spend 2 days kind of in intensive consultations and educational sessions and hands-on training. We've been doing that successfully, I think about 6 or 8 rounds, and 180 CME credits have been claimed for that. And it's been a real success so far. We've produced, if you recall, I talked about how often these our studies that we publish in peer-reviewed scientific journals are not really going to be easily picked up and read by your rural clinician who's not affiliated with a university. And so we've created 30 or more kind of deliverables to help try and get out the information on recently completed studies and other evidence-based methods in a more digestible brief form. We've done a lot of TA support, especially around the harm reduction, but as well as smoking cessation and med safety. So you see that on the right side of the screen. In fact, we've disseminated so far over 350,000 supplies, especially related to harm reduction over the first 4 years. And then lastly, we just have over time developed a pretty robust online or virtual digital platform for dissemination of these our deliverables and information and education. I guess to sum up from both the experimental and kind of more implementation science realms that we've been focused on for the past few years, I think, we still have challenges in Vermont and pretty much most of the areas that we talk to rural providers in terms of still there remaining some room for improvement in the addiction treatment capacity in rural areas. We've certainly been experienced a lot of hunger from rural doctors for the types of support that I described today. Some of the top themes, as I mentioned, have been around getting assistance with complex patients, improving patient adherence, and reducing the probability of med diversion. Dosing questions, especially with fentanyl now out in the drug supply, moving people to buprenorphine can be dicey, or tapers, and so that can be that's a big source of questions that we're getting. And then the harm reduction, of course, and overdose prevention, especially with not only fentanyl but xylazine increasingly present. We've been having a good experience with our kind of interdisciplinary team of faculty, clinicians, researchers, staff. That's worked well. I don't know that you would need to have such a village approach, but I think it's a strength that we've been appreciating of our center. And then we've also, I think, had a positive experience and are hearing good things from rural providers in terms of our ability to offer support across multiple platforms, like you see here, like one-on-one peer consultations by phone, actually having staff come out to the rural practice to provide hands-on in-person training, really one-stop shop at their clinic versus them coming to UVM, for example, for more intensive training, and just individualized, personalized support and consultation to the provider and their needs. Overall, I'm optimistic that these efforts and many others and different other innovative approaches may actually help to continue to expand the availability of life-saving SUD treatment and especially OUD treatment in rural areas, and especially to support the providers that are on the front lines with the rural opioid epidemic. Just want to acknowledge all of our teams and the village. It takes a village, both in terms of our prospective randomized trials that we conduct with kind of our researcher hat, as well as the Cora staff that are so focused on dissemination and implementation science in the past 4 years, as well as our partners at the bottom, and particularly some great partners at University of Southern Maine and in New Hampshire as well. And that's it.